Okay, now we're going to transition into our therapeutic exercise or rehabilitation aspect of therapeutic interventions, right? So this is the basis of designing a rehab program. What I did is I took the first three chapters of the apprentice textbook and kind of combined everything into one little lecture here. And a lot of it you guys already know, right? Like the rehabilitation team, group effort, AT, patient, physicians, coaches, strength and conditioning specialists or coaches. Patient's family have a question mark next to just because of HIPAA laws and FERPA laws. You may not be able to involve the patient's family. Um, I think that's pretty straightforward. And I think you know what an athletic trainer is by now. Otherwise, you probably wouldn't have applied for the program, right? It's involved in initial injury to unrestricted return to play. You know the responsibilities, and you know we work under supervision of a physician. Treatment philosophy is something that I think is tough when you're still a young professional, such as you all are right now, right? Treatment philosophy, there must be an understanding tempered by flexibility, and variations occur athlete to athlete and physician to physician. But your own treatment philosophy, you can start to develop your own philosophy right now, right? As you're learning some of the basis and basics of therapeutic interventions. And as you get out into the profession and go to more continuing ed and learn more, you can actually, evolve that treatment philosophy. Communication is obviously critical on all levels with the patient, with the coach, whoever it might be, right? But definitely with the patient. And trust and confidence. A lot of this stuff, as you can see, I'm going to go through pretty quickly. Philosophy of a sports medicine rehab environment is unique in sports medicine, right? Most athletes that are patients want to get back as quick as possible, right? So aggressive approach to rehab. That competitive nature to athletics necessitates an aggressive approach. Now, when I was younger in the profession, I'd get in trouble sometimes because I'd push them back so fast and try to push them so hard that I'd actually not injure them more, but prohibit or prolong some of the stages of inflammation and healing that they were in, right? So as I've gotten older, I've kind of backed off a little bit and calmed down with that. Healing process, we did this early on in the summer here. I think it was one of the first couple lectures that we had. You know this. So based upon where they are in the healing process, you can progress through the rehabilitation based upon where they're at in that healing process of the injury process, right? The psychological aspect, that's a whole chapter in this textbook. Most places have whole courses designed around the psychological aspect of injury, right? So critical factor often neglected and overlooked. Individual responses vary from emotional responses. Pain thresholds, as we know, competitiveness, as we know, can change by individual cooperation and compliance. And then, depending on the patient, they may go through depression, anger, fear, guilt, and depending on what type of injury it is. I like the kinetic chain. It's an integrated functional unit involving muscular system, articular system, neural system. So muscles, bones, joints, and nerves, right? Each system works to provide structural and functional efficiency, and the central nervous system facilitates neuromuscular control by sorting cumulative information from all three systems. So it's getting information from muscular, bony, joint, right, and neural nerve, and the central nervous system is filtering out what's important and what might not be important. Now, functioning system could result in a compensatory overload, which can decrease performance and predict injury patterns. Kinetic chain rarely involves, injury rarely involves one structure. So you need a global approach to rehabilitation program, as you can see here. I have a lot of dancers that come in and say, okay, my mid back or my upper back hurts, and you know what? I might not even touch their back. I might go right to their neck, do something on their neck based upon a functional movement eval type thing, and bam, their mid back pain goes away, or their knee hurts, and I go to their their hip, their pelvic girdle, do something at their pelvic girdle, and their knee pain goes away. People think I'm nuts when I do that, but I think that the rest of this course that you'll have in the fall and spring semesters with Marcy, um, her and I actually share a lot of the same rehab philosophy and treatment philosophy. So I think that you guys will get a very similar point of view in the next two sections, I guess, in the fall and the spring from her. So functional movement, function and kinetic chain, right? Function is integrated multiplanar movement requiring acceleration, deceleration, and stabilization. So if I raise my hand, that's one plane. If I come out, abduction, right, that's one plane. But if I'm a golfer and I go up and through multiple planes, right, that is an integrated multiplanar movement. Very few activities take place in one plane, right? This functional kinetic chain rehab is a comprehensive approach, improve all components necessary to allow a patient to return to a high level of function, and must address functional strength, muscular efficiency. All functional activities are multiplanar. Yes, they are, right? They blend acceleration, deceleration, and dynamic stabilization somewhere in the body for optimal efficiency, essentially. Understanding that functional movement rehabilitation paradigm shift, so training the entire kinetic chain to establish high levels of functional strength and neuromuscular efficiency, and train to allow force reduction, production, and dynamic stabilization efficiently during movement. I think there's a big shift in the rehab world right now into looking at the entire body and making sure that you do a functional kind of screen beforehand. Can you predict injuries with that? And then based upon what you know, can you actually treat that patient differently now when they do get injured? You're going to hear everyone say this: avoid the Cookbook approach. Not every ankle sprain gets the same exact rehab, right? Not every knee gets the same exact rehab. Why? Don't do the Cookbook approach. What's best for that patient? What's that patient's goals? Right now, I'll say this: if you're working with a 90-year-old grandma, her goals might be a lot different than a 21-year-old that's going to the Olympics, right? Vastly different approaches to rehab. You noticed under tools, manual therapy is listed first. It's interesting. For athletic training education, with the huge shift to a master's degree, we have some new draft standards that we're going through, and I've been going in and developing our master's program here at my campus. And the crazy thing is the standards state very little on therapeutic modalities. There's actually one bullet point on modalities. There's 5, 6, 7 bullet points on the manual therapy, therapeutic exercise protocols, not protocols, but things like that. So it's interesting, the shift in the profession. Exercise versus conditioning exercise, right? Therapeutic versus conditioning. Yeah, exercise is essential to conditioning, injury prevention, and rehab. Unfit athletes are more susceptible to injury. We know that. If you're out of shape, if you will, you're more prone to having an injury occur. Engaging in training and conditioning is necessary to maximize the performance and hopefully minimize injury. Principles applied to the training are the same that apply during rehab, restoring body function. And therapeutic exercise is widely used to describe exercises associated with rehabilitation. Goals. You need to establish goals, all right? Rehab should be goal-directed. What are some short-term goals? What are some long-term goals? So you can see short-term goals here: provide immediate first aid and care. That patient gets injured right now at soccer practice. What are you going to do to immediate first aid and care? Are you going to ACE wrap them first, elevate, all that stuff, right? How are you going to reduce and minimize their pain? And then you can reestablish some stability, neuromuscular control, postural control, and whatnot. And you can see the rest of the list here. Almost always the long-term goal is to return back to play. And ATs that work in non-traditional settings, such as the industrial setting, If you're working for Boeing, the airplane manufacturer, their goal isn't to return to play. It's probably to return back to work, right? Or if you're working for Amazon, yes, Amazon has athletic trainers, right? Your goal might not, their patient's goal might not be return back to, I don't know, 100% capacity at doing this certain job at Amazon, but it might be shifting jobs and shifting different priorities, right? So that's a conversation you must have with that patient. Make sure, though, the goals are reasonable and obtainable, right? If you're working, I don't know, high school baseball with a high school baseball athlete, and they might not be the most fit athlete or the best athlete in the world, and they think their long-term goal is to play professional baseball in the major leagues, sometimes you may have to knock them off a little bit, if you will. Yeah, avoiding exact time frames or dates, because you may meet those, but you may not. And if you put, you're going to be back 100% of your strength in 2 weeks, you don't know that. There's no way for you to know that. So avoid exact time frames or dates. Be encouraging, right? And encourage them to meet sequential challenges involving increased skill and ability. And the athlete should be involved in the rehab process, obviously actively engaged. So throughout any rehab program, we establish core stability, essential to rehab process. Lumbo-pelvic hip complex works that dynamically stabilize the connect chain during movement. You can see this girl's on the TheraBall, physio ball, whatever you want to call these things, right? And she's doing some kind of chop with it, all right, with the weighted medicine ball, it looks like. Reestablishing neuromuscular control, so joint position sense, so where your joint is, or proprioception, essentially. So if my finger's up in the air, I have proprioceptors in my joints, right, that know that my finger's here. But when you injure your finger, say I sprain my finger in a basketball game, right, those proprioceptors, GTOs, also get damaged. So reestablishing proprioception, neuromuscular control even, is mediated by mechanoreceptors. It relies on the central nervous system to integrate proprioception and kinesthetic information, translating it into movement. Injuries alter this ability. So I would say Greg Cook has a good book out there called Movement. So if you look at a baby, you don't tell them how to roll, they crawl, right? They just do it. And they usually, start rolling and they have no pain. In an adult, if you try to roll right now, you couldn't do it. I'd say, there's 6, 7 of you guys in the class, probably 5 of you could not roll. I can't roll. So literally lay on your back. I do it here, but you can't see me if I lay on the floor of the office here. Lay on your back, take one hand over and try to roll your left without using any other part of your body. Can't do it. You see an infant, a baby, they're going to be able to do it. Why? We'll get there. If I don't get there, Marcy will in the fall. Postural control and stability, integrating muscular forces, neurological sensory info, biomechanical info. You need that postural control. Decreased postural control may be linked to deficits in proprioceptive function, muscle weakness. So I have poor posture. I blame it on doing my dissertation and a lot of my doctoral work, because I was always at a computer. I'm always sitting there typing, writing things down, researching articles, all that stuff. So now I have a forward head posture. All right. My thoracic spine has more of a kyphotic curve. So if I turn to the side here, you might be able to see, right, my forward head posture, my ear doesn't line up with my AC joint. My ear, that's a big difference, right? My thoracic spine is a little more kyphotic. My shoulders are rounded. 4 or 5 years ago, I wasn't like this. What happens now is I have something called upper cross syndrome. Everything here, my pecs, are tight, and my muscles in my thoracic spine are weak. They're elongated and weak. Restoring range of motion. We'll have a whole lecture on range of motion. So some range of motion things we'll talk about: musculotendinous units, muscle imbalances, postural imbalances, neural tension, joint dysfunctions that can cause some loss of range of motion. Physiological movement constraints and accessory motion deficits must be determined and treated accordingly. So do we do this through stretching, joint mobilizations, traction? And we're going to have a whole lecture on this, muscular strength, endurance, and power. So we're going to skip that for now. This is a plyometric exercise. You can see this individual is doing some kind of wood chop. This actually doesn't look plyometric to me, but it's a photo, so you can't really tell. Plyometrics are usually incorporated in later stages of rehab and relies on quick eccentric stretch to facilitate subsequent concentric contractions. So remember, eccentric muscle lengthening, concentric muscle shortening. So if you quickly lengthen the stretch and then facilitate subsequent concentric contraction, you can actually build speed, power, right? So that's what this person is doing. Open versus closed kinetic chain. All right. So deals with functional relationships in lower and upper extremities. An open kinetic chain, foot or hand is operating in space. Right, hands out here. Closed kinetic chain, foot or hand are weight bearing. So if I put my hand on the chair here, that is now closed kinetic chain. Closed kinetic chain exercises incorporate isometric, concentric, and eccentric muscle contractions simultaneously in differing muscle groups within the chain, right? So isometric, bam, my right arm here. This is a wall, let's say. I'm pushing into the wall. Yes, I'm getting some forearm movement, but I'm getting a lot of bicep strength here. But the bad thing with isometric is I am only strengthening it right here in this specific unique angle pattern, right? Can be beneficial, especially like in a quadriceps after an ACL reconstruction. Tighten the quad, relax the quad, tighten the quad, quad sets, essentially, right? Concentric, bam, biceps curl. My biceps are shortening and strengthening. Eccentric, I'm now lowering the weight very slowly back down, and now my biceps is eccentrically lengthening and working in a different pattern, if you will. Cardiorespiratory fitness, I think, yeah, and the book agrees, most neglected aspect of rehab. Whenever you have a patient out for, more than a couple days at least, you need to be addressing their cardiorespiratory fitness. If they have a lower body injury, can they do pull work? Can they do an upper body ergometer? It's literally a bike for your arms, a UBE, right? If they have an upper body injury, can they hop on the bike? Can they go in the pool? Can you figure out a way to try to maintain somewhat their cardiorespiratory fitness? It's functional progression. So progressive activity is designed to prepare a patient for return to activity. So skill acquisition and reacquisition within limitation of injury and rehabilitation, that progress is based on injury response. This functional progression will help the injured patient return to normal, pain-free range of motion, right? Strength and neuromuscular control. So stabilization, strength, power. Do you do power before stabilization? Probably not, right? You need to build a strong base here before you build up on top of the pyramid, right? Stabilization phase, exercises that are designed to correct the deficits in the structural integrity of the kinetic chain. These deficits must be addressed prior to beginning aggressive rehab. You correct muscle imbalance, recondition injured structures, prepare tissues for demands, right? Prevent tissue overload, improve work capacity, all these different things. I can't talk. Exercises should progress from isometric, bam, to multiplanar, going up at different angles. This is a P&F pattern, proprioceptive neuromuscular facilitation pattern. You recruit joint stabilizers that improves neuromuscular efficiency, functional strength, functional flexibility. How do we do that? You'll learn throughout the fall and spring semesters. The strength phase enhances stabilization, strength, and endurance during functional movement patterns, incorporates high-volume resistive exercises that forces motor unit recruitment after prime movers are fatigued. The goal is to choose several adaptive changes, such as challenging the neuromuscular system, increase the cross-sectional diameter of the muscle, increase resistance to fatigue, stabilization strength to control joint movement during functional movement, right? And this power phase is important for an athlete returning to a high-level activity. This is incorporating multiplanar, concentric, eccentric, even isometric contractions to increase strength. Sometimes during this power phase, it's not the AT that is really working with the patient directly. It might be the strength and conditioning coach, right, or specialist. Functional training. These are drills used to assess athletes' ability to perform a specific activity. It may involve a single maximal effort, but commonly used tests are like agility run, sidestep, vertical jump, hops for distance, co-contraction testing. This person is doing probably a hopping drill, right? Single leg hopping drill. Criteria for full recovery. So what is complete recovery? Well, it's restoration to normal functions, all aspects, determined by nature of injury and philosophy of the physician to a point and the AT, based on objective and subjective criteria. And the physician really does have the final say in return to play. Factors that can be considered or to consider for return to play: physiological healing constraints, pain, swelling, range of motion, strength, and muscular control, respiratory fitness, sport-specific demands, functional testing. Are you going to use prophylactic strapping or bracing? Are you going to tape their ankle or put them in a knee brace? Legal considerations, so educational backgrounds, licensure, and certification are controversial in considering patient care. Yeah, so laws do vary state to state with regard to an athletic trainer's ability to conduct rehab programs. AT should be sure to operate within the limitations of respective state laws. And I laughed here when I got to this slide because I'm going to pick on personal trainers. That sounds bad, but personal training has a unique niche in the fitness industry. They're not physical therapists. They're not athletic trainers, right? They're their own unique profession, if you will, right? A lot of personal trainers have some good background, right? They have degrees, they have certifications that are pretty legit, but I know of a bunch of personal trainers that literally have had no background and have taken what is it, the ACE exam, I believe, right? I can't think of what it is, what the ACE stands for now. Literally, you have to be 18, over the age of 18, and have CPR certification to get your personal training certification from this one organization. That's scary. They have no educational background, but then they're trying to help people, after an ACL reconstruction. Don't let that happen. Don't do that. Evaluation is kind of a foundation of rehabilitation. So you must be able to perform a systematic evaluation to determine the athlete's needs. And I believe you guys will have eval classes in the fall. So some of this foundational stuff might get a little ahead because you haven't had rehab class or eval classes yet, but that's okay. Syriac, so James Syriac, I believe, was a PT that actually wrote a lot of different manuscripts, articles, had a lot of different evaluative techniques by applying the knowledge of anatomy to differentiate between provoked and normal tissues, right? So provoked tissues, let me back up here. Provoked tissue, normal tissue equals pathological tissue. Pathological tissue with no contraindications equals treatment. So pretty much, find what the tissue is that is being provoked, find the normal tissue, and figure out what you can do to make sure you can treat them with no contraindications. Syriac actually has a lot of good ideas and theories out there. We did a lot of stuff with Syriac during my doc work. Reevaluation is critical. Monitor the progress. ATs, as you'll learn, conduct multiple evaluations for different reasons. You could do an on-site eval at the time of the injury, so you go out on the field, court, whatever. On-site eval just following the injury, so they come off the field, they're doing it. Off-site eval following injury assessment and rehab program. Follow-up eval, right? Pre-participation in physical eval. you'll learn the differences between all of these more in depth in eval classes. The way I would evaluate a patient on the field is a lot different than I would evaluate them in the clinic, right? So if somebody tore their or injured their knee, I go out there on the field, I'm going to do check for fracture, rule out fracture, dislocation, any life or limb threatening conditions, check the stability of the ligaments, get them off the field. That's about it. On the sidelines or in the clinic, I can take my time and do a better, I shouldn't say better, more in-depth evaluation. Right? Classification systems. I think you guys are going to hear a lot more about different classification systems in the coming years when it comes to injury evaluation and rehabilitation treatment. If we can classify a patient into this group and do this certain type of intervention on them, we know that the success rate is this. There's going to be a lot of research coming out on that stuff, trust me. So joint adhesions, pain during activity that decreases with rest. So these are response of symptoms to activity, different classifications. Chronic inflammation, edema, morning stiffness that reduces with activity, joint congestion, pain or aching that worsens with activity, acute inflammation is pain at rest, worsens at the beginning of activity in comparison to the end of activity, bone pain, peripheral nerve entrapment, and then intervertebral disc involvement. You can see these here. Range of motion, again, this determines the patient's ability to move limbs through a specific pattern of motion. You can perform it passively. You move the body part for the patient. Actively, they're moving it, or against resistance. Always compare bilaterally. Both hamstrings, both elbows, both whatever it is, right? Make sure you document what the degrees or whatever you're using to measure the range of motion was and compare bilaterally, because you can mark progress that way, right? It's active range of motion. The patient actively contracts muscles as they take the limb through a particular movement pattern. This evaluates the quality of motion, total range, location of pain, different painful arcs maybe. Limited range of motion could be caused by swelling, joint capsule tightness, agonist, muscle weakness, inhibition. So shoulder's pretty easy to do. Shoulder flexion. You can see if they have any pain within the arc here. I do. I get about almost 90 degrees. I have a little pain right where my biceps, long head of my biceps tendon is. Right? Passive range of motion, a little different. The tissues are relaxed. You move it. You can actually assess endpoint feels. So it's kind of crazy. We'll hopefully get to do some of this stuff in the lab. You can stretch the hamstring. You can feel that tissue tightening in that hard endpoint and that stop, right? Capsular patterns of motion, so joint capsule irritation may cause a progressive loss of ability or available motion in different planes. Each joint has a specific pattern of progressive motion loss. And then non-capsular motion, patterns of motion. And CRX has the 3 different classifications here: ligamentous adhesion, internal derangement, and extra-articular lesion. Accessory motion, joint play, arthrokinetic motion. Motion occurring between 2 joint surfaces. Right? It's required for full active and passive range of motion. You have roll, glide, and spin. So these 3 terms come into play when doing a joint mobilization. You need to know roll, glide, spin. We're not there yet. We will hopefully get there a little bit next week, but I don't want to confuse you yet, right? Hypomobility versus hypermobility. Hypomobility is the patient has less motion than they should, right? We see this a lot with males and hamstring range of motion. I shouldn't say almost all. Most males have decreased hamstring range of motion or tight hamstrings compared to females. All right, hypermobility, too much movement in a joint. We see this a lot with dancers. When I treat this one dancer, she will be a junior next year, I believe. She has the craziest range of motion I've ever seen. She can put both legs behind her head and both arms behind her head at the same time. It is the creepiest thing. But she has hypermobility. And the issue with this is she has pain. She has a lot of pain, but she has a lot of thoracic spine pain, and it's due to her hypermobility. These joint mobilizations may need to be incorporated into the process to treat restrictions, right? So if range of motion limitations are due to ligamentous adhesions or tightness, we can do some joint mobs. I love joint mobilizations. Resistive strength testing. Yeah, so strength testing. Use to assess status of contractile tissue. Assess using isometric or break tests. So mid-motion or motion-muscle testing. Isolation of contractile tissue. You can look for accessory or compensatory motion. The way we kind of teach it at my institution is you have specific muscle testing. We break out every muscle in isolation, and we can kind of break that muscle out, or do a break test, or and it's graded numerically, 0 to 5 scale, and you can compare bilaterally. It's one of those things that we still do, and ATPT physicians do it, but it's not the best measure. But there's no other, I guess, better way to assess this. I don't want to take much stock into the specific manual muscle testing personally. You'll learn this in your eval class. Specific how to break out each muscle, right? Muscle imbalances, I definitely think, is something that we overlook too much, right? Assess patterns of kinetic dysfunction, either muscle tightness or hyperactivity, and the tightness or hyperactivity in the agonist may result in the antagonist inhibition or reciprocal inhibition. Interesting, right? What does that mean? So if I have tightness in my hamstring, my antagonist quadriceps may result in antagonist inhibition. My quadriceps might be actually a little weak because my hamstrings are tight. Weird, huh? Impact on postural alignment. They alter joint position, allowing for increased shortening and ultimately stretching of the antagonist muscle. Right, so if tight muscle, like my rounded shoulders here, my pec is tight, so my shoulders are rounded. Or my shoulders are rounded, so my pec is tight. Which came first? I don't know. But my antagonist, right, my rhomboids on my back, right, they're now stretching. So this alteration of these length tension relationships, potentially additional disruption of force couples and postural alignment can actually cause injury. So you can follow this: prolonged tissues, postures of repeated contracture, reciprocal inhibition, alters force relationships, bam. So you can follow this right through the numbers. I'm not going to hit this in depth here. Muscles can be divided into groups based upon muscle imbalances noted by Vladimir Yanda. PT, awesome dude. You will learn so much about Yanda. I know Marcy is a huge Yanda fan. Why? We did a lot of projects together and PhD stuff, or DAT stuff, I should say. All right. Yanda. Yeah. Movement muscle groups. They're prone to developing tightness, more active during functional movements, more active during fatigue or new movements, and tend to be hyperactive. So your hamstrings, they help you walk, right? They're prone to tightness. They're prone to all those things. Stabilization. Your glutes, your obturator, pelvic girdle, essentially, right? With more muscles, but just let's pelvic girdle. Keep it easy. They're prone to developing inhibition and weakness. They're less active during functional movement. They're easily fatigued during any dynamic movement, and they have reduced force capacity due to that fatiguing and less activeness. Is that a word? Yeah. I love Yanda stuff. There's a couple books out that I actually don't have here because I'm at the house. In the office, I have them now. Muscles in the movement group are prone to develop tightness and weakness. The reestablishment of muscle balance for you must stretch tight, shorten muscles, followed by strengthening a weak antagonist to restore normal force couple. And then if you fail to address imbalances, this limits the effectiveness of a rehab plan. You only will treat the symptoms and not the cause. So what I said earlier, right? If I have a dancer who comes in, their knee hurts, and I work on their neck, their knee pain goes away. I'm not treating their symptoms of their knee pain. I'm finding the cause of their symptoms come from their neck. And that's functional testing, if you will. So functional performance testing is a little different. Tools to use to assess patient function and progress. Functional movement patterns, these should reflect the types of stresses the patient will actually experience during normal activities. So a functional test. There's a lot of outcome measures out there that you can use to assess how well a patient is doing. I used one for my dissertation that was called, what was it called now? Oh my gosh, patella tendon. Can't think of what it was called now. Oh my gosh. I spent 4 years working on this thing. I can't remember. Anywho, it's an outcome measure that it's scored on a 0 to 10 scale, 10 being the best though, 0 being the worst. Kind of odd because 0 for pain is the best, 10 for pain is the worst. So it's a little opposite, right? So I would have them do 3 functional tasks, whatever they wanted. For the dancers, it was almost always squatting, walking upstairs, and something else, right? So I would test them before. All right, you do this activity, write down what your score is. Remember, 10 is the best, 0 is the worst. And then I would do some kind of manual therapy on them and then regrade them. They would regrade themselves. Almost always we would see an increase or closer to 10, all right? This is a functional test. It's good because it can help me see the benefits of my intervention. Is it actually working or not? So functional screening tests should be performed during pre-participation exam. So this would be a functional screen different than functional performance. So the functional movement screen, FMS, right? 0 to 3 scale. 0, you have pain. 3, you have the perfect movement. 1 and 2 in between, right? Pretty easy to do. I'm sure you guys will end up learning FMS stuff later in the year with Marcy. Really, the unique thing with the FMS is the SFMA, the Selective Functional Movement Assessment. As athletic trainers, we are allowed to do a selective functional movement assessment screen on patients. Physical therapists, physicians, chiropractors, and athletic trainers are the only 4 groups of professionals that can do this. Personal trainers cannot do this. That's against the law, right? Strength and conditioning coaches cannot do an SFMA. They can do FMS all they want, but they cannot do an SFMA. The first thing I do actually when I treat a patient is do a quick SFMA on them, figure out where I think they have a dysfunction, and try to fix that dysfunction to see if it helps their other pain, right? So one common one is an overlay head and single leg squat. This is used to identify movement impairments that could cause and then perform direct treatment. So overhead squat, you literally squat with your arms above your head. Single leg squat, hands on the hips, and you squat. You look for ability to maintain a neutral alignment, limb segment alignment. Yeah. It's more in depth than this slide is going, and that's kind of why I'm not putting much weight into this slide, because when you do it in person, it's going to be a lot more intense. Oh, here's the FMS, right? I forgot this was in here. This bridges the gap between the pre-participation exam performance testing. There's 7 fundamental movement patterns that require balance and stability and mobility. Every deep squat, hurdle, step, inline lunge, shoulder mobility test, active straight leg raise, and then trunk stability, push-up, and the rotary stability test, which is pictured in your book. Ordinal scale, 4 possible scores, 0 to 3. 0, you have pain. That's when you stop, and the SFMA should be done. But remember, personal trainers, strength and conditioning coaches, strength coaches cannot do SFMA. AT, PT, chiropractor, and physician and DDO can do SFMA. The LESS is the landing error scoring system. Did a lot with this at Old Dominion. I did my master's degree at Old Dominion with Jimmy Onati, one of the professors, to help kind of develop the landing error scoring system. Used to really identify individuals at high risk for ACL injury, jump landing, vertical and horizontal movement, You jump from a 30-centimeter box to a distance of 50% their height away from the box, and you immediately rebound for max vertical jump on landing. You count the landing airs. Usually we videotape these in the lab, and then we can go back and make sure we got all the airs correct. It's just one example of a injury screening test that you could use. There's hundreds out there, honestly. But what is in the literature the most? Probably landing air scoring system. You need to document things you do in rehab, right? If you didn't document it, it never happened. So if you ever get sued, you're in big trouble, right? So you need complete and accurate documentation. Clear, concise, accurate records are necessary for third-party billing, which we're not there yet for AT necessarily. It can be time-consuming, but you need to be proficient and be able to generate accurate records based on evaluative process performed. So the most common, I guess, way to keep a note is a SOAP note. This record keeping can be performed systematically, which outlines subjective, objective findings, as well as immediate and future plan. So S would be the subjective, statements made by the patient, primarily history. Patient's perceptions including severity of pain, mechanism of injury. So patient may say, I stepped on a player's foot, my ankle turned in, I felt a pop. My pain was an 8 out of 10. Bam. That goes in subjective, plus more, right? Objective would be findings based upon your clinician's evaluation during the objective portion of the eval. So you say, yep, there's moderate edema to the right ankle. Range of motion was 5 degrees of dorsiflexion, 2 degrees of plantar flexion, blah, blah, blah. That's objective data. The assessment is what your professional opinion regarding the impression of the injury may include suspected site of injury, structures involved with rating and severity. So you might say, okay, possible grade 2 sprain to right ankle to the anterior talofibular ligament. And then your plan would be, includes first aid treatment, referral, goals, plan for treatment. The plan would be, okay, ACE wrapped, elevated, non-weight bearing on crutches, taught patient how to walk up downstairs using crutches. Short-term goal would be to reduce edema, decrease pain, blah, blah, blah. Long-term goal would be back playing soccer or basketball, whatever. And then this is the plan for treatment. You need to record evaluation information should be as qualitative or quantitative as possible to facilitate monitoring progress during rehab and make adjustments accordingly. Almost all places use electronic health records or medical records now, right? So sportswear, there's so many different companies out there that have electronic online records right now. So sportswear is probably one of the most common ones. Sims is another one. So you can type this in on your cell phone, iPad, you have to log in, right? But with technology these days, it's pretty easy to do. And the thing about SOAP notes is if you work in a large clinic or a large practice, right, you have 7, 8 athletic trainers with you on a daily basis. Maybe you have off a certain day or you're traveling a certain day. You're not going to always treat that patient. You need to keep accurate notes in case somebody else is treating that patient, right? Now, if you're the only one in the clinic, still keep accurate notes, but you should know what you're doing on a daily basis, all right? So rehab goals, we talked about this earlier. Yeah, so progress evaluation. So when rehab is occurring, follow-up evals must be performed to monitor progress. If you see that patient daily, that allows for daily modification. But these progress evaluations should be based upon healing process at any given time. This provides a framework for the rehab and sometimes constrains some progress. So generally more limited in scope. It focuses on the specific injury and progress relative to previous day. So every day you might do a progress note, right? So patient came in today, says the 3 exercises we did yesterday went well. The last exercise, TheraBand caused some pain on the lateral aspect of the ankle. Pain is now a 6 out of 10, which was an improvement from yesterday. That would be in the subjective. Objective, okay, it gained 5 degrees of range of motion and plantar flexion today, blah, 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 right? So you can do that on a daily basis. Yeah, so history, observation, palpation. These are just examples that you can look through of ideas of questions. Special tests, you guys are not there yet. You have not learned any special tests. You'll learn this in evaluation classes. Yeah. So again, a lot of this is a introduction material, right? And I took all this info from the book. I literally went through, actually downloaded the book's PowerPoints and went through the book, and figured out, okay, what are some basis of injury design, basis of designing a rehab program that we haven't talked about yet, and going over the therapeutic modality aspect. And here's some basic intros to a rehab program. So next week we are going to actually do, I believe, range of motion, flexibility, right, strength, proprioception stuff. So probably be 3 or so lectures on that stuff, and then that's about it. Semester is almost over. We'll do a little bit of manual therapy. Awesome. Again, if you have questions, concerns, email me.